All right, so I'm Courtney. I'm a speech pathologist here at Providence Regional, and I am talking today about the nursing swallow screen protocol here, as well as our speech pathology swallow evaluations. So the first thing that I want to talk about is the difference between the nursing swallow screen and the SLP swallow evaluations. So in fact, the difference is just that basic, is the RN swallow screen is a swallow screen versus the SLP evaluation is an evaluation. So the screen is just that. The screens are completed by the nurses, whereas the evaluations are completed by the speech pathologist. So the swallow screen is just very brief. It just wants to take a look at the patient's swallowing ability right at that second to determine if they're able to eat and drink and take medications at that time, okay? The swallow evaluation is more in-depth. It's an actual evaluation of the patient's swallowing ability. It's done by a trained licensed speech pathologist, and it evaluates the presence or absence of dysphagia, aspiration risk, and whether or not the patient is able to safely consume a diet, whether or not it needs to be modified or not. So the nurse's swallow screen should assess the likelihood that the patient is able, assess the likelihood that a swallowing issue exists, so whether or not they're able to swallow right then, okay? Determine if a swallowing evaluation is needed from a speech pathologist, and determine right then if the patient can eat and drink something safely. What a swallow screen should not do is it does not evaluate the swallow function. So it does not tell if swallowing function is functional. So it never does a swallow screen say, oh, swallowing is completely functional. It does not diagnose dysphagia or state if the patient's at risk for aspiration. And it does not reveal if the patient needs a modified diet. So if the swallow screen is completed, it just says the patient is able to eat, and if they can eat, it should be the appropriate texture given their dentition, or they cannot eat, and that is it. So the reasons we use the nursing swallow screen are to assess our patients that are at high risk for having swallow trouble or dysphagia. So this could be our neuro patients, patients that are increased risk for lung infections such as pneumonia, patients who have a brief intubation, poor nutritional state, especially if maybe there's concern that that could be related to swallowing difficulty. If there's concern for swallowing difficulty after a cardiac surgery or a neurosurgery. Of course, all stroke patients, any change in neuro status, or if a physician has deemed it medically necessary for the nurse to screen their swallowing before they're able to eat and drink anything. So there's two parts to the nursing swallow screen. The first part consists of a brief history review. So that's where the nurse asks if there's any dysphagia history, any trouble eating and drinking, any consumption of a modified diet at baseline, a brief oral motor and cognitive screen. So, are they awake? Are they alert? Do they have a very significant droop? Things like that. That would be something of concern for allowing them to eat independently. And then the 3-ounce water challenge. The second part of the screen is only completed if they've passed the first part of the screen. And that second part of the screen is the observation of the entire first meal, either by the nurse or the CNA. So there are some absolute contraindications to completing the nurse swallow screen. So the first one is if they're unable to remain alert and participate. So if they're somnolent, if they can't stay awake for more than a couple seconds, they're not appropriate to be given water, right? If they're eating a modified diet due to a pre-existing dysphagia, then you don't give them the 3 ounces of water. If they have a G2, any history of dysphagia, it's an automatic fail. Okay, if there's head of bed restrictions, so any of our patients where there's concern for like a spinal precautions, anything like that. If they have a trach present, regardless if it's a brand new trach placement or if it's a chronic trach, something like that. And if there's an intubation greater than 48 hours, or if it's a confirmed stroke in the brainstem. And then those two are bolded because those two are new additions to our swallow screen policy here. If any of these exist, what the policy here is to make the patient NPO, contact the physician, and get an order for the swallow evaluation, as well as to get an order to give meds in an alternate means. Okay. All right, some reasoning behind the two changes. So for prolonged intubation, essentially what some of the research says is that intubation, what makes it prolonged is anything greater than 48 hours. So that's kind of the cutoff. 48 hours and beyond is prolonged. Some of the research looks at what the increased risk for dysphagia is each day that somebody's intubated beyond that 48 hours. And it was found by one of the researchers that each day of intubation increases the risk of dysphagia by 14%. Okay. It was also found that, depending, of course, on the population and depending on the reason for intubation, but patients who have prolonged intubation have a risk between 50% and 84% of dysphagia. And also patients who have had intubations for at least 7 days they're at significant risk for at least a moderate to severe dysphagia. So a lot of research here supporting why we wanted to add this, because these patients are at significant risk for dysphagia aspiration. So it was determined that these patients are at such high risk that they needed to have an evaluation rather than a screen. As far as the patients with the brainstem stroke, just a little bit of the dysphagia statistics. So following an acute stroke in any brain region, okay, research says between 29 and 67%, okay, can have dysphagia. Aspiration can occur in general population of stroke between 30 and 51%, and silent aspiration can range from 8 to 27% in the general stroke population. Now, the risk for dysphagia in brainstem can be up to 81%. Okay, so significantly higher, and again, that's why the decision was made to kind of take the ability away to have that screen and go straight to the evaluation, because that risk is so high. If potentially 81% of those patients are going to have dysphagia, it's for the patient's own safety that they get the evaluation versus the screen. There we go. Sorry about that. All right. So the nursing swallow screen, the nurse has done the brief history, they've done the oral mechanism, the brief screen, they've done the brief cognitive evaluation, and now it's time for the 3-ounce water challenge. So the key here is that you have to drink the entire 3 ounces, and it has to be 3 ounces, and it has to be done in a cup with a straw, and it has to be in sequential sips. So the key is you cannot stop between swallows. It has to be continuous movement. You cannot have any rest breaks, any stops. If you stop in between, then the movement of the swallowing mechanism stops, and then it doesn't do the same assessment. What the research looks at here with the 3-ounce water challenge is that 3 ounces is the minimum amount of water that it takes to do in sequential sips to identify a risk for aspiration. So if you do less than 3 ounces or you don't do the sequential sips, then you're not really assessing what you need to assess. All right, so if the 3-ounce water challenge is completed correctly, then it does actually have pretty good accuracy for predicting aspiration, 96.5%, okay? And that was from a study that did the 3-ounce water challenge and then looked with an objective swallow evaluation of fees, which is an endoscopy, and confirmed the aspiration. But however, the caveat to that is if the swallow screen is not completed accurately, so they're not doing 3 ounces exactly, they're not doing the consecutive sips, then the research doesn't support any of it. And it essentially is an invalid assessment and doesn't assess the patient's risk for aspiration whatsoever. All right, so if somebody passes a 3-ounce water challenge, they were able to drink the entire 3 ounces in consecutive sequential sips without any signs or symptoms of aspiration, so coughing, choking, okay? If that happens, the nurse marks a pass in the flow sheet, okay? If they have no teeth, they get put on a pureed diet. If they have adequate dentition, they go on dental soft or regular. Those are the only modifications that are allowed to solids. Even if they pass the 3-ounce water challenge, that does not mean that their swallowing is intact by any means. That means that they can drink 3 ounces of water without coughing and choking on it, okay? An SLP evaluation may still be indicated, as it does not assess anywhere their ability to tolerate solids, chew food, their ability not to choke on food, so they may still need diet modifications to assess their ability to tolerate solids or have any modifications there. So after they pass the 3-ounce water challenge, there has to be a full observation of the first meal, and it has to be the entire meal. It can be done by the nurse or the nursing assistant. And what they're looking for is any difficulty, coughing, choking, throat clearing, difficulty clearing the mouth, if they're holding all their food in their mouth. This is a screen as well. It's not an evaluation. So what they're looking for, are they having difficulty or not? If they're not having difficulty, then it continues to be a pass and they're doing okay. If they're having difficulty, then the nurse goes back to the flow sheet, changes the pass to a fail, makes them NPO, consults the doctor again to get the order for the speech pathology evaluation, gets the change in the route of the medications, and then the patient gets seen by the speech pathologist. A fail for the 3-ounce water challenge would be if the patient coughed or choked on the water during or while drinking or immediately following drinking. It's also a fail if the patient was unable to drink the 3 ounces of water in consecutive sips. So even if they can drink 3 ounces of water, if it's not in a continuous movement, it does not count. Reasons why they might not be able to drink it in the consecutive sips may be due to dysphagia for one, maybe it's due to fatigue, respiratory compromise, maybe they're very confused, maybe the aphasia is impacting them, they can't understand what they want you to do. It doesn't matter. If they cannot do it, you cannot adequately assess their aspiration risk, and therefore they have to be evaluated by a speech pathologist. All right. So if the patient fails, they get marked as a fail, made NPO or kept NPO. The doctor is notified, get the order for the speech pathology evaluation, and get the medications to be given in a non-oral means. And then the key here is that once a patient fails the nursing swallow screen, they've been deemed unsafe to eat and drink. They cannot be rescreened for any reason. They must remain NPO until a speech pathologist can see them. The reason for this is it's a screen. They've been screened, they've been determined to be at risk, that's it. Then they need an evaluation. You can't just rescreen somebody because each time you screen them, you're putting them at risk. All right. So then if they fail the nursing swallow screen, then they get the SLP evaluation. And what the SLP evaluation is it's a formal skilled evaluation where the speech pathologist looks for different things like the presence or absence of dysphagia. We evaluate their risk for aspiration. We evaluate the need for diet modifications or different liquid textures that they might need for referrals to different disciplines like GI or otolaryngology. Maybe different compensatory strategies that they might be able to use to stay on less restrictive textures but in a safe way, or need for objective swallow evaluation such as a video swallow. So there are different types of dysphagia. You have oral dysphagia, which is trouble with the oral phase or chewing things, manipulating the food in the mouth, propelling the food backwards to swallow, clearing the oral cavity. There's the pharyngeal phase, which is getting the food safely from the back of the throat down into the esophagus. And trouble in this stage typically results in penetration or aspiration or airway compromise. We also have oral pharyngeal dysphagia, which is difficulty in the oral stage and the pharyngeal stage. And then you have esophageal dysphagia, which is dysfunction within the esophagus. So that would be more of like the reflux, that type of thing. The esophageal dysphagia is not evaluated by speech pathologists. That's done by GI. Dysphagia can result from a variety of things. It can be neuro in etiology, it can be due to confusion, it can be due to many different diagnoses. So it doesn't have to be necessarily related to something to a stroke. If there's concern, it's better to just have a speech pathologist come in, do the evaluation, and then we can determine if it's related to something that's acute in nature, if it's chronic, or if it's something that maybe is an acute exacerbation of a chronic issue. All right, so what we're looking for, the big thing, is penetration or aspiration or airway compromise. When they swallow, does the food or liquid go down towards their stomach, or potentially is it going down towards their airway? So penetration is described as food or liquid that goes into the upper airway, and it remains above the level of the vocal cords. Okay, aspiration is described as when food or liquid goes below the level of the vocal cords. Signs or symptoms of aspiration are things like coughing, choking, throat clearing, change in vocal quality, wet, gurgly voice. Not all aspiration and penetration is audible. There is something called silent aspiration, and it is that silent. So the most important thing here is that they're not going to have that overt response. The way that you evaluate, or the way that a speech pathologist evaluates for silent aspiration, is to do an objective swallow evaluation like a video swallow or a FEES. and where we actually can see via x-ray or, with a endoscopy down to the airway and see if something is going into the airway and see if they have that over response. Now, if they are diagnosed with silent aspiration and we put them on a modified diet and then the nurse or somebody gives them something that's not that consistency, the key is they're going to look okay. You could give them an entire glass of water and they can drink it down and they're not going to cough, they're not going to choke, but the potential is that they're aspirating it, okay? So that's always something to keep in mind, that just because something looks okay doesn't mean that it is. Different diet modifications that we have here at Providence, we've got dysphagia puree, dysphagia mechanical, dysphagia advanced, dental soft, which is not a dysphagia diet, regular, and then the liquids, thin, nectar thick, honey thick, and then pudding thick or spoon thick. And dysphagia diets, when a dysphagia diet is ordered or when the SLP is involved with a patient, any order for the nurse to advance diets as tolerated is no longer valid. Once an SLP is involved, the SLP is the one that then modifies the diet. So if the diet needs to be advanced or if unfortunately, it has to be downgraded, that's going to be the SLP. Depending on the patient, they might need a day before they're seen again, they might need a couple days, but that's going to be determined by their plan of care. And sometimes they have to, really prove their tolerance of one specific texture before they're ready to advance to another texture. If they're on a modified texture, such as the honey thick liquid, even if the order doesn't specifically say no thin liquids, no ice chips, it implies honey thick liquids, nothing thinner. So whatever the diet is, they can have more restrictive textures, nothing less restrictive. Okay, so if somebody was on a nectar thick liquid diet, they couldn't have ice chips. Okay, if somebody's on a dysphagia mechanical diet, they can't have a slice of bread, but they can have purees because purees are more restrictive. A slice of bread is less restrictive. A couple tricky ones: ice chips, popsicles, ice cream, Jello are all thin liquids. So if you're on a diet where you require thickened liquids, none of those are appropriate. Some general aspiration precautions. Now, patients who are on the speech therapy caseload and who have been identified to be at risk for aspiration or have a dysphagia will get a yellow swallow sign. And what this sign is it has their diet, it has the way they should be taking medications, and then it has patient-specific precautions and strategies that they need to be safe. So it's posted behind the bed, and it's imperative that if the patient transfers rooms, the sign goes with them so that they can be safe regardless where they end up in the hospital. Because if the sign doesn't go with them, then the new nurse coming on is not going to know those precautions. Generally, patients in the hospital should abide by just basic aspiration precautions, sitting up, making sure that they're adequately awake, different medication times. Patients may be required to take medications at night. They still need to be sitting up. They still need to be awake. And alert, a slow rate of consumption. Patients in the hospital unfortunately get confused. So depending on their cognitive status at that time, they might require supervision, they might need some assistance, and unless, they've been identified as a risk for aspiration around the speech pathologist caseload, that's going to be up to the nurse's discretion. And then also, even if they pass their nursing swallow screen, it's still the nurse's job and the CNA's job and everybody involved in that patient's care to continually see how they're doing with their meals. And if they're showing signs or symptoms of aspiration or difficulty, or they're not able to clear their mouth, to ask for a speech pathology order when it's appropriate. All right, and that is it. Any questions?
Yeah, actually,
Yeah.
one time there's a nurse from Illinois.
Mm-hmm.
I think he did the swallow evaluation because he thought in the ED patient was sleepy, so they failed the swallow screen. And so when the patient is more alert and hungry, want to eat, so he did another swallow screen again.
So
So
if they're marked as a fail, they can't redo it.
That's why I think what
Yeah.
you say.
Exactly. So if the patient is somnolent, then they shouldn't be doing the swallow screen. If they're marking them as a fail, means that they tried the swallow screen and that they failed it. Mm-hmm. So if they're too lethargic to do it, then they can hold doing it for that's second, until they're a bit more awake. But if they're doing the swallow screen, marking them as a fail, they cannot redo it.
Okay,
Yeah.
so I think it is needed to reinforce that eight.
Once a fail, always a fail, because it just gets too risky, you know, because then you have to go into, you know, what level of documentation there was. Having the idea that maybe they were too sleepy down in the ED is not adequate for redoing a swallow screen, you know. Did that nurse specifically talk to the nurse in the ED? Was it documented that the nurse did the swallow screen when they were too sleepy? And then the question is, why was that nurse doing a swallow screen when they're too sleepy? I mean, if the nurse thought they were too sleepy, why are they trying to give them 3 ounces of water? Would be the next question. So if they're failing the swallow screen, they have failed the swallow screen. So, you know, if the nurse has deemed them awake and alert enough to try to drink 3 ounces of water, and they cough and choke and maybe they were a bit sleepy, then you know, the nurse needs to be aware of doing assessments when the patient's awake and alert. So if the patient's not awake and alert, the nurse should be using basic judgment and not trying to feed a patient.
Yes.
I think the thing to remember is that the screen is looking for the potential that there's a dysphagia. So if there's anything that gives a potential,
Lethargy.
Lethargy is one, but somebody asleep is not participating in any of this. So they didn't really do the screen.
Yeah.
So, you know, they have to be able to at least kind of start this to say that they failed the screen.
Yeah.
I think that's where the confusion comes through. This is a question I have. Are they just marking it fail down in the ED because these folks are too sleepy, and they said that they did the screen because they're too sleepy, and that's number one. And so I feel like that's kind of an area where people are getting a little confused.
Right. Yeah, and then there's the other situation is probably in the ED, the patient has a little facial droop, so it just fell on the swallow screen, and when you come up to the
That is valid.
and then the patient feel.
They can choose that.
A nurse.
No, I totally understand.
Yeah.
But I mean, when the patient come up to the floor, the facial droop may be kind of diminished.
Right.
So the nurses feel like, okay, the patient looks good, so they redo the swallow screen.
But here's the
That's what-
thing, there was a facial droop. With the facial droop, is there the potential that there's a swallow problem?
Mhm.
Yes,
Yes.
there's a fail. It doesn't matter what they look like in an hour.
And with neuro patients, it fluctuates. So maybe in 30 minutes, the facial droop comes
Yeah.
back.
And the reason I brought this up is because I want the nurses to hear what you guys say.
Yeah. I mean,
Since it's a recording.
yeah, so there's, I mean, with those kinds of questions, I mean, yes, I see how it can be tough if a patient had a facial droop and then the facial droop was improved and they're hungry, and I understand that. But, you know, with a facial droop that was so significant that the nurse felt that it was too risky to feed them, the risk for dysphagia is huge, right? You know, and if it resolved, you know, that significantly, there's not any guarantee that it's not going to be one of those waxing and waning neuro cases that we've seen, that in a couple hours it's back. Maybe more mild, maybe just as significant, you know. The thing to remember here is that it's not to make the patients upset, it's not to make the patients feel hungry or be sad, it's to keep the patient safe. Because, you know, especially the neuro patients, having a stroke in different areas of the brain can lead to an aspiration event. It can lead to a choking event where they actually occlude their airway. And there have been stroke patients that have choked, and that has been it for them. And so silent aspiration is an issue, just aspiration is an issue, pneumonia, you know, sepsis from that is an issue, prolonged hospital stay is an issue. A choking event is definitely an issue, especially if they were relatively with it. Let's say they were eating unsupervised, let's say they choke, nobody hears them. I mean, it could be life-threatening. And so if the patient has been screened and determined to be at risk for aspiration for any reason, it's for the patient's best interest. Now, the patient may be upset about that. So the key is for the nurse to do the education and let them know why, you know, and let them know, that this is for their safety. Yes, we realize you're hungry. Yes, we know it's not comfortable, but, you know, you came in with this, and this. You know, the MRI showed this, this, and this is why we're doing this, because it's for you.
And I'm totally agree with you.
Yeah.
I told the nurse at that time, I say, once it fails, it's failed.
Mhm.
It's just they hear the different different story.
Yeah.
That's why sometimes still happen.
Yeah, and I think that, I'm a big proponent of the nurses using their discretion. If a nurse is looking at a patient and they feel very uncomfortable and they look at the patient and they say, I'm not giving this patient 3 ounces of water to chug, then that is completing a screen. That should be marked as a fail because the patient was awake. The patient was, looking at them. They could have given them the water, but they didn't out of, fear for that patient's safety. And they marked them as a fail, and that's perfectly acceptable. And I would rather have you do that than put the patient at risk, and then we can come in and do our assessment. And then if they look better 4 hours later, we will get there as soon as we can. But again, it's all in the best interest of the patient. And that's what we want to try to stress.
Thank you so much.